So I'm going to describe, first of all, the regulations that came into effect in April of this year and talk about focusing on dried cannabis. And I think that's important. What we're talking about with the new regulations is dried cannabis, not sesame or any pharmaceutical preparation. So when a patient gets a prescription from a doctor, they mail it to the licensed distributor, who then gives them a package. And the package is simply the plant, dried cannabis plant, that a month's supply or whatever, that they can then use as they see fit. So we'll talk about indications, contraindications, recommended dose, and strategies which are inevitably and already are occurring in terms of patient disagreements. So the new regulations, now Health Canada calls it a medical document. It's very important to understand this is a prescription. A prescription means that the doctor has decided that this drug is of medical benefit to the patient and directs the patient to take it, whatever they say, 1-3 times a day, this certain amount. It is a prescription. They are calling it a medical document, but that's what it is. The prescription specifies the amount of use per day in terms of grams and the amount to be dispensed per month. So they get this monthly package of whatever. And it comes in the mail. The script can be up to a year, but each package can contain no more than 150 grams, which amounts to 5 grams a day for 30 days. This has been objected to by every national major medical organization, the Canadian Medical Association, the College of Family Physicians of Canada, and the various provincial colleges have also said they all said they don't like it, but it's gone through anyway, so this is the law. So now we're going to talk about smoked cannabis or dried cannabis, and again emphasizing that I'm not talking about Sesamet or Sativex, which are the two main pharmaceutical cannabinoids that are available in Canada. I'm just talking about studies on dried cannabis. There to date have been 5 controlled trials on dried cannabis. And all these subjects had neuropathic pain. There were at least 2 trials on patients with HIV neuropathy, and then there was a couple of trials on patients with multiple sclerosis, spasticity, and neuropathic pain. And then there was 1 trial with a variety of neuropathic pain conditions, including post-surgical. The total number of subjects in these trials was only 180. The duration was very small, only 3 to 5 days, 3 to 15 days. And smoked cannabis was compared to a placebo cigarette and not to other treatments, not even to oral cannabinoids. And there we could find, or I could find, only 1 trial comparing dried cannabis to oral dronabinol, which is Marinol, which is not really used much in Canada. And in that study, dronabinol had a longer duration of analgesia than dried cannabis. And in fact, so it was superior in terms of pain relief because it's metabolized in the liver to active metabolites. The adverse effects and safety. There was a meta-analysis from 2009 of 18 controlled trials using cannabis therapeutically. And these were all preparations, not just smoked cannabis, mainly, in fact, pharmaceutical cannabinoids. And they found a significant, not surprisingly, a significant rate of basically intoxicating effects of cannabis. That is, perceptual distortions, effects on motor function, and effects on cognitive function. Now, these were all short-term trials, so, the clinical significance of this is not certain. However, it is very concerning that, you have a medication that basically causes intoxication, and if we're prescribing it for chronic pain for long-term use over months or years, it's not really very acceptable. So the concerns with smoking is a highly unusual delivery system. There's no other medication that is delivered through smoking. And there's 2 issues with smoking. One is an extremely high rise in serum level because You know, there's 50 meters of alveoli in the lungs, and it gets absorbed right away. It's even faster than intravenous use, and it reaches the central nervous system, the blood in the central nervous system within seconds. So a very rapid rise and high peak, and then a rapid decline. So if you're actually treating chronic pain, this is exactly the opposite of what you want in a drug. You want, when a drug, you want something that doesn't cause intoxication, so and yet provides long-lasting pain relief, so you want a steady state. Furthermore, smoking has hundreds of toxic products of combustion, some of which are known carcinogens. There has been, although this is controversial, there was actually a really good study done in Sweden now on following patients from the Swedish male army conscripts from the time that they were, admitted or enlisted in the army until many years later. It was like 20 years follow-up on tens of thousands of males that showed a higher risk of lung cancer in patients who smoked cannabis. Now, obviously, they said that they controlled for confounding with cigarettes, but, it's still controversial. But it wouldn't be surprising biologically if marijuana was linked to cancer. Similarly, it has been linked in small case studies to precipitating myocardial infarction and cerebrovascular accidents in younger patients who are heavy smokers, probably through vasospasm and an acute rise in blood pressure. There's very good evidence, I think, that it increases the risk of motor vehicle accidents, and I'll be talking about that a bit differently. It does it differently than alcohol. Alcohol increases in patients who drink too much. It increases risk-taking and impulsivity, as well as decreasing motor coordination. Cannabis, actually, patients who smoke cannabis are not bigger risk takers, but they have trouble with complex driving decisions, turning left at a busy intersection, for example. So it does work in synergistically with alcohol to increase the rate of motor vehicle accidents. Furthermore, I think there's quite convincing evidence now through case control and long-term cohort studies that smoking cannabis is a risk factor for schizophrenia, particularly if it started at a young age among adolescents, and presumably in patients who may be genetically vulnerable to it. So cannabis use in adolescence is actually a very different kind of pattern of harm. With alcohol, with opiates, with other drugs, the pattern of harm is seen primarily, not exclusively in adolescence. It's more broad across the spectrum, more in young adults, 20 to 30, and then it diminishes, say, alcohol, 30 to 40. With cannabis, the harms are very much focused on adolescence. So in terms of psychosocial harms, poor school performance, poor work performance, depression, anxiety, other illicit drug use, there is a hypothesis that this is because cannabis as a hallucinogen affects the developing brain, which doesn't really fully develop until adolescents are in their mid-20s anyway. Some people say, well, it's a case of cause and effect. Is this an association or a true cause? We don't know for sure because these are epidemiological studies, but it certainly appears that in some of the cohort studies that the harms of cannabis, the cannabis use precedes the harms that you see. So we know anxiety is a common reason for smoking cannabis, that many medical users will say, I'm smoking cannabis to relieve anxiety, but yet we know that it can actually trigger panic attacks de novo, and that very low dose THC may in fact have anxiolytic properties. Higher doses appear to actually contribute to anxiety. And this is part of the problem with cannabis. It's a very complicated drug. The two active ingredients are cannabidiol and THC. And it appears that THC is the one primarily responsible for cognitive impairment and the intoxicating and euphoric effects of cannabis. But many of the possible therapeutic effects of cannabis, including pain control, may be due to cannabidiol. So we know that cannabis use disorders are common. and that cannabis is associated with a withdrawal syndrome, a physiological withdrawal syndrome characterized primarily by fatigue and anxiety. Cannabis use in pregnancy, it's contraindicated in pregnancy. It has been linked in a dose-related fashion with neurodevelopmental effects. Where do we go from here? Given the new law, and given that the evidence for benefit and the evidence for safety is considerably stronger for nabilone and for Sativex than it is for dried cannabis, we are working on guidelines through the College of Family Physicians of Canada, and we're coming up with preliminary guidelines, and we are going to recommend that cannabis be, in all cases, be given an adequate trial orally and buccally, because that's what Sativex is, as an oral buccal preparation, before trying dried cannabis, and that dried cannabis be reserved for severe neuropathic pain syndromes that have not responded to standard treatments. So that's going to be our recommendation. Now, the reality is that most patients who are requesting medical cannabis do not have neuropathic pain conditions and have not been given an adequate trial of oral cannabinoids. So what do we do now in terms of an approach? So we do need guidelines. So this is what we're recommending as the indication for smoked cannabis. Non-indications, what we're saying is that most people, the evidence suggests most people who use medical marijuana for pain are using it for common pain conditions seen in primary care, like low back pain and fibromyalgia and headache and so on. And we're saying that, in fact, it shouldn't be prescribed for that, given that dried cannabis hasn't been studied for these conditions. There's a high likelihood of harm, and that there are effective and safe alternatives. Contraindications, we're saying it's contraindicated in young adults of 25 years of age or under. And it's certainly contraindicated in patients with a current or past or strong family history of psychosis, in patients who are actually currently using or misusing another substance like alcohol or cocaine or other drugs. There is evidence that, well, let me put it this way, patients who have a cannabis use disorder along with a cocaine or alcohol use disorder appear to be worse off than if they have that cannabis use disorder, if they have that cocaine or alcohol use disorder alone. And of course, if they've been addicted to cannabis in the past or pregnant or current cardiovascular or respiratory illness. Precautions would be past substance use disorder if they're on high doses of opiates or benzodiazepines, if they have a current anxiety or mood disorder, and if they smoke tobacco. So again, the dilemma is most patients who are currently using medical marijuana, or that is marijuana and they claim it's for medical purposes, would in fact not fit into any of the indications that I've listed, and it would be contraindicated or not indicated. If you look at people who smoke marijuana compared to those who don't with similar pain conditions, the marijuana smokers are younger, they're more likely to be male, they're more likely to be addicted to other drugs, and they're more likely to have a concurrent mental illness. So there is a different demographic of marijuana smokers compared to regular pain patients. Now, one of the issues is dosing guidelines. And I don't know if any of you have ever looked on the websites of the various licensed producers of marijuana. It's astonishing. The strains of THC that they have are ranging from, 9% to 30%. In fact, most of them are 12% or over. And we know that that the complications and adverse effects of cannabis are dose-related, which is not surprising. The more THC you ingest, the greater the likelihood of motor vehicle accidents, of intoxication, of all the other harms that cannabis has. So what you have is street cannabis, that is cannabis grown at home. is actually less than 12% on average. We don't know exactly what it is, but it's probably considerably less than 12%. So what licensed producers are doing is actually they're selling cannabis, producing and selling cannabis that's more dangerous than street cannabis. So when Health Canada says, well, we're doing it for safety, and yeah, they do have regulations about secondhand smoke and the production of it and use of pesticides and, very quality assurance, but fundamentally they're making a product that the legal product is more dangerous than the street product. And, if one were to be, well, it's not really being cynical. It's just from an economic point of view, the licensed producers have a problem. The product they're making is actually considerably more expensive than street cannabis. So how are they going to make people want to buy it when they could buy it off the street? Well, yeah, go ahead. Thea.
No, I was just going to ask in terms of the new guidelines, hasn't it been established that how the government and how Health Canada was doing it is that they licensed it out to various producers who all had probably different strains and different concentrations, but the new regulations is licensing it, that there's a sort of Health Canada's production of it, and it's not being produced by various different growers. Regulate more regulated with the consistent dosing.
Right. So what happens before, there are 30,000 patients who got approval from Health Canada to grow marijuana for medical reasons. So a doctor would sign saying they have whatever, severe arthritis or HIV or something, and they were given a license to grow marijuana, and that license would specify a certain amount that they were allowed to have. How the patients got the dried cannabis was up to them. They could grow it their own, or they could purchase it, whatever. There were no regulations about the source. Health Canada said that's a big problem because, we don't know where it's coming from, and it could be criminal gangs and so on. So now it's illegal for you to possess or grow cannabis, no matter what the source or the reason. But they have...
Isn't it in the courts now?
Yeah, this is... Supreme Court struck that down, and it said that people who have a current license to possess medical marijuana are still able to do it legally. But it doesn't apply to the people who don't have a current license. But so Health Canada is now giving licenses to private companies, consortiums of businessmen and so on, to produce marijuana as long as they meet certain specifications. So it's like any other business. You can grow tobacco or broccoli or whatever you want as long as you meet certain conditions. But the conditions do not relate to how you market it, and they don't relate to the percentage of THC that you provide. So that's, in fact, on the prescription, there's no requirement to specify the percentage of THC, and I don't even know if legally the producers have to abide by a doctor who does say, I want this to be 9% THC or something like that. So it's a real mess. What you're trying to do, if you are going to prescribe marijuana to, for example, someone with HIV neuropathy, you want a dose that would be effective for neuropathic pain while not causing intoxication. And this would be similar to any other drug. If you're prescribing opiates, you want a drug that works as an analgesic but doesn't make people euphoric or sedated. Luckily for the great majority of drugs, the analgesically effective dose is considerably lower than the intoxicating dose. And that appears to be true with THC or with cannabis as well. So we looked at these studies, and we found one study that was good in terms of its specification of exactly how much THC was delivered. And in this study, they used 9% THC, and they showed that one inhalation of 9% THC, which is approximately 25 milligrams of cannabis, or 100 milligrams if you count the side stream smoke and so on, was effective in treating pain from various neuropathic pain conditions. And so that dose could be achieved through 400 to 500 milligrams a day of dried cannabis. So that is what we're recommending as a maximum dose, is 500 milligrams of 9% THC. So that would exclude the vast majority of strains, which are like 30%, 25%, 20%. When you look at those strains, you have to realize that those are untested, and they're almost certainly more dangerous than lower strains. Lower doses are recommended for patients with, various contraindications and precautions. So we're saying that if you do write a prescription, it should be for 500 milligrams a day maximum, 9%, which is about 12 grams, 15 grams for 30 days. Now, most medical users use 1 to 3 grams a day. So we don't know. Again, this may be a cause for some disagreement with patients and also some disagreements with producers. So we're not sure how this is all going to turn out. And obviously, you discontinue it if there's no analgesic benefit or if there are adverse effects. And these are standard, by the way. If you're prescribing cannabis as an analgesic, you want to see evidence of improved function or reduced pain. If you have a patient who is disabled by pain, that is to say, I can't work, I can't do anything, my back pain is so bad, we're saying if the cannabis doesn't improve their function, then stop it. Furthermore, we're going to say that, let's say you have a patient who is a heavy cannabis smoker, and they say it's helping their back pain. And you take a history and you find two things. One is that their function is very poor. They're not working, they're not engaged in family, they're just, and they're using high amounts. And after they smoke, they don't do anything. Then you would have to say, I know you think that this is helping your pain, but it looks to us as if the pain is causing you far more harm than benefit. Because if you give an opiate, for example, as an analgesic, what you should see is after I take the opiate, I'm more functional. I can get up and I could do my work and spend time with my family, etc., etc. If you give an opiate and the patient says, yeah, after I take it, I sit there and listen to music and watch TV for 4 hours, that's a failure. That's not an analgesic. That's something that's getting them intoxicated. So because I think this is going to be very important for doctors to sort out. In other words, just because a patient says that cannabis makes them feel better doesn't mean it's a good drug. Every single drug in the world will make people feel better. Alcohol, cocaine. You talk to someone who drinks a lot. Say, how does your alcohol affect your pain an hour, half an hour after having 5 drinks? And they'll say, yeah, I'm not worried about my pain. It really helps. Does that mean it's a good analgesic? No. You have to look at functional status. So harm reduction. I think these are advice to people you would give whether or not you're prescribing. Because part of your issue now is even if you're saying no to the person who requests dried cannabis, you'd like to know, you'd like to reduce their harm of cannabis use. Definitely vaporizers are effective in reducing the toxins that are available in cannabis smoke. So what vaporizers do is they heat the dried cannabis to a super high temperature, and the vapor contains THC. And that's a much better delivery system than combustion, which is smoking, which produces all sorts of side chemicals. And that's been, I think, shown especially for carbon monoxide. Don't mix with tobacco. A lot of people seem to mix tobacco and cannabis together. And of course, caution with alcohol, opiates, and other drugs. Don't breath hold. So breath holding means, you inhale it and you just hold it as long as you can. And that will, of course, increase the amount of THC absorbed and will cause greater intoxication. In fact, if the cannabis is effective for chronic pain, then all they need to do is take one short inhalation and it should be good enough. Caution with edibles. Now, edibles meaning, putting THC in brownies or something. That is better in terms of its less toxins. It's also probably better in terms of pain relief because it's a slower absorption and longer duration of action. But it can contain a super high amount of THC, and the patient doesn't realize it. They eat a brownie, they feel fine for half an hour, and then all of a sudden it hits them and they have a prolonged intoxication. driving, I think I talked about how cannabis has a different effect on driving than alcohol use does, and it also has a longer effect. So alcohol, is metabolized 1 drink an hour, so after an hour or two, patients are a lot safer to drive. The duration of cannabis intoxication is considerably longer. We're saying don't drive for at least 6 to 12 hours after the last use. Cannabis use disorder or cannabis addiction. This is the DSM-5 criteria. Here are the signs. The patient is smoking daily, usually more than 1 joint, but not necessarily. And they're spending a large amount of time smoking. Maybe every evening they're smoking cannabis and not doing much else. They may have poor social or work or school function compared to when they weren't smoking, or just they're not attaining what you would expect them to attain in terms of functional status. They are unable to stop or reduce their use, and they place a high value on cannabis. So this is the patient who says, I have terrible back pain, and I need to smoke 4 grams of cannabis a day to deal with that back pain. Nothing else works. Not opiates, not NSAIDs, not acetaminophen, not physiotherapy. Nothing else works, but the pain is still so bad that I can't move. Then you're wondering, well, if cannabis is the only thing that works and you feel your life will be over if you don't get cannabis, it certainly seems a pretty pathetically ineffective medication for pain control. And what that really means is that they're not using it for pain control. They're using it for its psychoactive effects to control their mood and to make them feel better. And they really do deep down need that drug. They feel that they cannot stand life without cannabis. That's cannabis use disorder. It would be the same criteria for opiate use disorder. If you have a patient who's on high doses of opiates and they're very non-functional, and yet they say, it only takes the edge off my pain, but I'm going to die if you don't keep on giving it to me, that's a sign of an opiate use disorder. So management, I would say don't prescribe. Refer the patient for treatment. This is management of cannabis use disorder. Counsel the patient. There's 2 things you really want to emphasize in your counseling. One is to address the prevalent view among youth that cannabis is a harmless herb. And we see this all the time. And you say, well, tobacco is a herb too. And there's lots of things that are herbs. Opium is a plant. And just to say, just because it's a herb doesn't mean it's safe. And also you realize that the patient feels better when they use cannabis. They're addicted to cannabis and they feel better. And what you have to say to them, and they may not believe you, is that if you stop or reduce your cannabis use, you will feel even better than you are now. Your function will be better, your mood will be better, your energy level will be better, you'll be enjoying life a lot more. So when you're talking about addiction, you don't want to say, well, it's bad to be addicted. You have to say, I am recommending you stop cannabis use because I know you'll feel better if you do. You'll feel better and you'll function better. So you're doing it for the patient's benefit. Sesamet or nabilone, there is some evidence that it does help with cannabis withdrawal. It's a similar principle as nicotine replacement therapy for nicotine smoking. So it is an option to consider as a prescribing to help people stop or reduce their cannabis use. What about patient disagreements? Well, we've thought a lot about this, particularly with regard to opiates. So, we all vary in our, how tough we are. I'm a marshmallow as a physician in the sense that if a patient wants an inappropriate test and I think it won't hurt them, maybe I'll say, yeah, okay, you can see that, get that referral for this benign thing on your skin, and I don't care about hurting the healthcare system, just get out of my office. You can have that approach, but one thing physicians never do, even the mild-mannered of us, will never do something that we think may harm a patient. That's a red line with us. So what we're saying when a patient asks for a cannabis prescription is that then if they smoke on their own and it's recreational, then it's up to them. We can advise them, but it's their choice. If you're writing a prescription, you are making a decision and telling the patient, whatever you told them, you are giving the patient the message that this medicine is more beneficial to you than harmful to you, and I want you to take it. That's what a prescription means. So, if you don't believe that, and if you think the medication cannabis may harm the patient, then you have to say no. That's your responsibility as a physician. First, do no harm. I cannot give you this dried cannabis prescription because I believe it will be harmful for you. And that's what the evidence suggests. So I know the temptation is to, okay, they're already smoking it, so what's the big deal? Well, there is a big deal because these medications, cannabis, can be harmful to patients. Actually, I want to go into one thing. Where did I put it? Oh yeah, referrals related to that. There are now in Toronto and throughout Canada, but there are several clinics that are calling themselves medical cannabinoid clinics, where you refer a patient to them and they will, then make a decision about prescribing dried cannabis. And again, as a family doctor, I think it could be very tempting to say, yeah, then I don't have to worry about it. That doctor will prescribe it. I think that is a mistake unless you have a certain comfort level with that cannabinoid clinic. I would say absolutely do not refer to any clinic that charges patients for anything. And the reason for that is what these clinics are doing now is charging the patient to fill out the medical document. Now, we cannot charge patients to write a prescription, but we can charge patients to write an external medical document. And so they charge $400 to write this medical document, even though it is a prescription. And I think there's an element of unacceptable coercion in doing that, because you're telling a patient, okay, you want this drug. In fact, the only way you can get this drug legally is from me. Otherwise, it's illegal and you could go to jail. And I'm going to make you pay $400 if you get the drug, but I'm not going to charge you anything if you don't get the drug. That's a type of extortion, if you ask me. I think it's unethical and unprofessional, and I don't think that we should be encouraging that type of medical clinic. If they don't charge fees, well, we'll see. I mean, one would expect that they would do the same kind of service as any other pain clinic, provide a comprehensive assessment and management of the patient, and that they would have a prudent and evidence-based prescribing policy. If it turns, and there are concerns that this won't happen, we'll have to see. In Colorado, where they have, I think it was Colorado where they looked at this, where it is legal to prescribe medical marijuana, they found that the large majority of prescriptions, and with tens of thousands of prescriptions, were written by a small group of doctors. So it became a cannabinoid mill, or whatever you want to call it. So we don't want that to happen in Toronto. So I've kind of already made this point, that if a patient reports benefit from cannabis, just keep in mind that all drugs of abuse can relieve anxiety and pain temporarily. So you want to look at the patient's overall functioning, and you want to ask, if they say it's helping their pain, then in theory, they should have a puff, and they should actually be better able to do their activities of daily living. If they have a puff and they collapse in bed and don't do anything, that's an inadequate or unacceptable analgesic response. Again, the whole point is patient benefit. What about the patient who says, you're forcing me to buy cannabis illegally? Because in a way, that's true. If you don't prescribe it, then any cannabis they have is illegal. I think that what you're saying is that their cannabis use is potentially causing them harm, whether it's legal or not. And if the patient doesn't want to get in trouble with the law, then they should stop cannabis smoking. You're not telling a patient to buy cannabis. You're advising them to stop it from whatever source it may happen to be. I think I've kind of gone over everything. We have maybe 15 minutes or so for any comments or questions. Yes?
So thank you for your talk. I mean, I think it's something that a lot of the practitioners here have been working with a lot of patients over the years who either smoke recreationally or who we have had on the program. We have a lot of patients with HIV. So I guess I have a few questions. One is other indications in terms of why people derive benefit from smoking marijuana. So historically, chemotherapy or drugs that cause nausea. Do you have the same approach for people who say, I get a lot of benefit because I'm cachectic and I'm not eating and it helps stimulate appetite or control nausea?
Yeah, that's a good point. Our work on the guidelines focused on pain and secondarily on anxiety, because a chronic non-cancer pain, because those are the two primary primary reasons why people report using medical marijuana. I think there is some good evidence that cannabinoid products are useful for chemotherapy-induced nausea, and they do appear to be an appetite stimulant. So I would say that, again, if you assess a patient and they're smoking cannabis and they have a serious illness that's causing weight loss and so on, and they report that it's stimulating their appetite without any evidence of harm, I would say, yeah. So you're right, I didn't talk about many of the indications. Nausea and vomiting and cachexia are two of the indications. But having said that, when you see the sort of propaganda in the media, and they manage to find one patient who's dying of cancer who says that this helps me, you have to realize that is not the typical medical marijuana patient. The patients that are demanding marijuana from doctors are, like I say, they're young men with rather dubious biomedical pain conditions.
The other question I had was, a lot of these companies now, they're sending the literature our way, these suppliers, and they have different strains. So the CBD has a higher proportion in some products, and the THC is much less.
Right.
So would you feel differently, perhaps, or should we perhaps be using some of these products so that there's less emphasis on intoxication and more emphasis on better pain control if you have higher?
I think that's a very good point. I would say that you would think that products that had higher cannabidiol would also have lower THC, and that's true sometimes, but not always. So I would say look on the website and pick a product that has the highest proportion of the cannabidiol and the lowest proportion of THC, because some of the literature on cannabidiol is pretty promising, both for pain and for addiction. And when the thing by Dr. Gupta, Sanjay Gupta on CNN on seizures, what wasn't emphasized enough, at least in the reviews of that, they were talking about a preparation with no THC. It was called Charlotte's Web. It was pure cannabidiol that was given to these children who had intractable seizures, and it seemed by their case reports to be a benefit. Cannabidiol, though, you can't give THC to children. It's just remarkably dangerous. But cannabidiol seemed to help them. So I would say that, yeah, absolutely. Look at the cannabidiol. But just because it has a higher cannabidiol doesn't mean it has a lower THC. That was kind of surprising to me when I looked through it. So, yes.
So, given I can't remember where I saw this pop-up of a cannabis medical facility, but I think Young and Eglinton,
Yeah, there's one in Young and Eglinton. Yeah.
Or is there already had a big profile on the owner? If a patient chooses to go there, they obviously don't. They not do referrals to these places, and they come to you and say, "I'm now receiving my marijuana through one of these places," and they're a regular patient of yours. Do you have a strategy to deal with that?
You're right. As far as I know, they don't actually need a doctor's referral. I'm sure they would like a doctor's referral, but I don't think they need it.
These are MDs, I think, that run these.
Yeah, they're generally MDs and right. Yeah, they're not necessarily charging a consult note. I don't even know if they're automatically sending a note back to the family doctor. I would say that, if a patient is getting a script from another doctor, what can you do? If I had a patient of mine that was getting a high dose from a cannabinoid clinic, I would complain to the college. That's what I would do. But, that's a decision. If you think that person shouldn't be on cannabis and they're getting Getting it from a medical cannabinoid, I think that's unprofessional and it's harmful to patients. But otherwise, you have no choice.
Can you make the parallel with double doctoring?
Well, the legally, what Health Canada has come up with proposed changes in its regulations, and they're asking for public input up until July 13th or something. The changes are that they want to force licensed distributors to reveal all the information about the doctors who are prescribing and the patients to Health Canada, presumably to the police or whatever they want. So they could, in theory, detect double doctoring or, cannabinoid, mills to produce tons of cannabinoid clinics. I don't necessarily have an objection to them. I think that they're trying to divert concern about cannabis onto the doctors rather than onto their terribly misconstrued or misthought out policies. I don't think that if there are harms arising from this, they're coming from bad doctors. They're coming from a cynical and not evidence-based policy around it. But that's my own opinion. So I'm not sure. In terms of double doctoring, I don't know. It doesn't really fit the legal definition. I know, maybe it does. I'm not really sure. I can't answer that question, to tell you the truth. But yes.
Sorry, I have another question. Some of us attended the OHTN this was research day, where Dr. Mark Ware from McGill spoke.
Mm-hmm.
And I must say the tone of his talk was much different than your tone. So I'm curious as to, I know he's a family practitioner, has an active practice and does research in the area. And in terms of the guidelines that are being developed by the College of Family Physicians, whether he's on board with that or is he taking a different tack if you have experience working together? I know it's probably a difficult question to answer, but it's just, I don't know if others feel the same, but the talk...
That Mark Ware knows about the guidelines and he is dead set against them. I'll just put it that way, because his view is that we need to do more research and there are benefits, and in my view, he mixes up everything. You try and pin him on, we're talking about dried cannabis, you know that, right? That's what you say to him, and it's, yeah, but cannabinoid receptors and all this. I said, we're not talking about oral cannabinoids. We're not talking about new research on synthetic cannabinoids. We're talking about a plant that you are advising people to smoke and inhale into their lungs. Now, and then it becomes, a little bit more dicey. All I can say is that we are profoundly in disagreement, and I think he's wrong. So I don't know how else to put it. I really think that anybody who's looked at this evidence objectively is going to come up with very similar concerns than ours. So, and I think that, we are being led down the garden path by licensed producers, just like tobacco companies. Exactly the same approach, down to refining the product to make it very potent. That's what nicotine companies did. The tobacco that Christopher Columbus was smoking did not have the same concentration of nicotine, not even close to the one that we smoke nowadays. So, and the same kind of advertising and the same kind of, they get these physician spokesmen who say how wonderful it is, just like opiates back in the 90s. And I just hope that doctors continue to use their independent judgment to not fall into this.
One more question, but I'll let you. Sorry, go ahead.
My question relates to that. So, because I have had HIV positive patients who've come and who have in the past smoked and then who've asked me to try the prescribed oral form. And so, would you consider that to be a safe alternative, or what concerns would you have about that, other than maybe intoxication potentially effects? That is an issue, but do you have any safety concern about the oral?
Well, I think that the oral and the buccal can certainly cause intoxication, but it's less likely to because the serum peak is much less. In fact, when I looked at it, it was a factor of at least 10 between what you would get with smoking and what you would get with oral, say nabilone. Sativex is actually a really good medication. It delivers almost as much as what I was saying, one puff. But it's very safe. It's a mixture of THC and cannabidiol. It's no toxins, and the serum level is not going to go super high. It's a metered dose. Unfortunately, it's expensive. I don't know how it compares to buying dried cannabis, but it is expensive. It is covered under the EAP program, but only for multiple sclerosis, for spasticity. So I would say that the cannabinoids are a better bet. A lot better bet. And so if you have a patient, I think they are now starting to be on algorithms for management of neuropathic pain, where more along fourth line, after the opiates and the anticonvulsants and the antidepressants and et cetera, you will see cannabinoids being considered, and I have used them. And I think they're a lot better bet.
And just in view of your opinion about the risks of smoked cannabinoids, like would you consider it a harm reduction strategy for someone who say doesn't have pain but comes in saying I'm smoking it but I want to try the oral instead? Then would you?
Well, I think it depends if they're not using it for pain. If they're not they're using it to get high. You mean they're using it for mood control? If they're using it for mood control, then they're not going to like the oral because it's not going to give them that nice feeling. However, if they are experiencing withdrawal symptoms, that is, they report, I'm having trouble getting off, then I think it's reasonable and very safe to give them oral as a way of just ameliorating or mitigating the withdrawal symptoms. I think that would make sense. And just getting back to Thea's point, I was just thinking, when we are thinking about, issues of jail and harm reduction and all that, the major source for adolescents, there's one brilliant study done in the States, the major source of cannabis for adolescents who are attending a treatment facility was registered medical marijuana users. That's where they got their drug. So when you're when doctors are prescribing cannabis, you have to remember that you are giving them a product that's highly desirable. It's got very high and known THC level. It's like, they can legitimately go to patients and say, wow, this stuff is really, really pure, really good. It's pharmaceutical grade. So there is the public health benefit. We are not really sort of protecting the public if we prescribe indiscriminately. Yes?
Thanks for your presentation. I have two questions. One is if you've seen any sort of people using, consuming, so they want to, I've sort of seen this where people say, oh, well, I'm not smoking it, but I'm eating it, like I'm basically consuming it, brownies or whatever, and if that is something that you see sort of commonly where people are, again, using it for pain control, but actually trying to ingest it rather than smoke it, and how you approach that. And then the other is, given that now 2 states in the U.S. have legalized marijuana for sale, how do you think that will change, the discussion in this area?
Right. So those are 2 good points. I actually have 2 patients that I have written those older things for. Both were older patients. Both they didn't actually have neuropathic pain. One had rheumatoid arthritis and the other had severe degenerative disc disease. Both were primarily using it by eating. And they would also create these tinctures. It seems like more placebo, but they would rub it on their skin. Neither of them smoked it, and neither of them used large amounts. So it seemed to be, and they felt it helped their pain, and it seemed reasonable to me. I don't know if I'd do it now, but that's what I did then. So I think that people who do use it for pain, the older patient with a true biomedical pain condition who says they have a little bit and it helps, whether it's smoking or vaporizing or oral, I don't have nearly as much problem with that. But when you get a 30-year-old who is, also drinking and using cocaine and stuff, and he says he needs it for his terrible headaches, I think that you're just doing them a disservice. So a lot depends on the patient. Similar with opiates, right? Same kind of thing. In terms of the legal aspect of it, I think that there would be of social value to decriminalize at least and possibly legalize marijuana. And this is, as doctors, we don't have any more credibility than anybody else in this argument, but I think that people can agree that putting people in jail or giving a young person a criminal record, which can destroy their life simply because of possession or whatever, is not a good idea. There's no social benefit to it. Being in jail is, in fact, making them more likely to do criminal activity when they leave. So there's no benefit to that. But making marijuana available through this is not going to help the vast majority of people who are smoking. In fact, this clears the way for the government to slam the marijuana users and the marijuana dealers. So let's not think that we're doing some kind of good social policy by having this prescribing. It's not. It's not going to help the large majority of people who are continuing to buy marijuana from the street. In fact, we don't know how it's going to play out, but the stuff from Colorado suggests that this is not hurting the black market. With alcohol it did, because when the prohibition ended, alcohol was now not only cheaper, but way, way safer and better than the black market, distilleries or whatever they were called. So yeah, it wiped out the black market. But nowadays, you can get pretty good THC for a lot cheaper and a lot easier on the black market. And all this is going to do is going to add to the mix in terms of illicit drugs. So that's my take on it from a social policy point of view. I don't think we doctors should be, I think we've been made the fall guys by the government. You know, go complain to your doctor if you want marijuana and leave us alone. That's my view of it. Yeah.
One more question, thanks. The former program, we would fill out the forms and basically say, this patient claims to derive benefit for such and such a reason.
Right.
Whereas now it's actually a prescription.
Right.
So I see it as a little bit different in terms of liability risk. Do you see that there's a difference in the fact that now when they fill out the paperwork, it's an actual prescription as opposed to?
Absolutely. Before, it wasn't a prescription. It was basically an authorization or approval. The difference is we are always authorizing things. Oh, you want to go on vacation, or you want to take a week off work, you want to, it's okay for you to climb stairs, it's okay for you to have sex or whatever. We're not telling people to do things. We're just authorizing. We're saying, from my point of view, it seems to be okay. It's medically safe. That's an authorization. A prescription is totally different. A prescription is, as your doctor, I am telling you that for this particular medical or psychiatric condition, that I'm directing you to take it as prescribed. And it means something totally different to patients and to the courts. So I would say yes. I would say, and now that Health Canada is saying, well, we're allowing doctors to prescribe it, and we're making it essentially legal, and you can write a prescription, and they've even given a huge product monograph, because that's what it is, indications and so on, but we're not really approving it, and we want to get the names of the doctors who prescribe it for whatever purpose we want, which may include complaints to the college, complaints to the police. It's like, I think they're jerking doctors around. If they don't think that it's a good product, then it's their responsibility to not allow it to be prescribed. But anyway, that's the reality. So yeah, I think when you're writing that prescription, you're giving a medical directive to a patient that you think it will be of therapeutic benefit to them.